Welcome, everyone. My name is Marieli Moronta Sanchez, and I am the Director of Community Outreach at the Rutgers Institute for Health, Healthcare Policy, and Aging Research. Rutgers IFH is a health research institute focused on improving population health with a deep commitment to health equity. Our community engagement core has partnered with Su Salud and New Brunswick of Tomorrow to present with you all today great information on brain health and preventing dementia. Our presenter, Dr. Michelle Chen, is a core member of the Institute for Health, Healthcare Policy, and Aging Research, and an instructor in the Department of Neurology at Rutgers University. Following her presentation, I'll ask a few questions. If you have any questions, please place them in the comment section. Thank you all for joining today. Take it away, Dr. Chen.
Thank you so much for the introduction. And thanks for having me today to talk to you about a really important topic on maintaining brain health and also preventing dementia. So, sorry. All right. So these are my funding sources. I don't have any conflicts of interest that's related to this presentation. So for today, I'm going to first talk about the spectrum of cognitive decline. So from what we see with normal aging to decline that might be due to a specific brain disease. And then I will talk about common brain diseases and syndromes that might affect individuals as they get older, and as well as how we assess it and how we treat those diseases. And then I will end with some strategies that people can do to try to maintain their brain health. So first, it's normal for our cognition to get worse over time as we age. So we might become more forgetful, we might be slower in processing information, and we might have difficulties with more complex activities that we normally did before without difficulty. So things like planning and problem solving. But it's really when your cognitive abilities are worse than people who are at the same age as you, that when we suspect maybe there's a brain disease going on, and they might fall into categories of either mild cognitive impairment or dementia. So mild cognitive impairment is when someone has some modest cognitive decline that's relatively to how they previously functioned, and their everyday activities might require more effort for them to do. So they might have to compensate more to complete their everyday activities, but they're still independent, meaning that they still can do those activities by themselves. But for others, as the disease progresses, they might experience significant cognitive decline. And now they might require assistance with their everyday activities, such as paying bills and managing their medications. So for those individuals, then they might fall into the dementia category. And dementia is really an umbrella term for symptoms of significant decline and having difficulties with their everyday activity requiring assistance, but it doesn't say anything about what might be the disease that's underlying the dementia. So next, I'm going to talk about some common brain diseases and syndromes that might cause dementia as individuals get older. So the most common cause for dementia is Alzheimer's disease. In fact, majority of the cases of dementia are Alzheimer's disease. And the Alzheimer's disease is a result of buildup of abnormal protein fragments and tangles in the brain. So they're called beta amyloid plaques, and also neurofibrillary tangles, and that causes the disease. Currently, 6.2 million Americans are living with Alzheimer's disease, and this number is projected to 13 million individuals by the year 2050. And the risk for Alzheimer's disease actually gets more likely as someone gets older. So the majority of people with Alzheimer's disease are actually at least age 75 and older. In terms of symptoms are associated with Alzheimer's disease, the most prominent symptom is memory loss. So initially, someone with Alzheimer's disease might have difficulty with learning and remembering new information. But as the disease progresses, they could also start to lose some of their long-term memory, such as not being able to recognize their family members. Language problems are also common in Alzheimer's disease. People might have difficulties with word finding the right word for certain things. They might have difficulties with general knowledge of different concepts. So for example, if I ask them, what are things I can find in the kitchen that might have difficulty thinking about, are the objects are in the kitchen that's associated with that concept. They might also have difficulties with more complex activities. So for example, shifting between different tasks that you're doing at the same time, problem solving, monitoring your own behavior. And then some people might also have difficulties with processing visual information as well. And in fact, there's actually an atypical presentation of Alzheimer's in which that difficulties processing visual information is the primary symptom and not memory loss. And that's called posterior cortical atrophy. So as the disease progresses, people might have difficulties with orientation. So knowing when it is, or where they are, and this disorientation and confusion combined with difficulty in processing visual information might result in people with Alzheimer's disease wandering off their home and getting lost. So that's definitely an area in which when someone's caring for someone with more advanced Alzheimer's disease, making sure that you are watching the individual, making sure they're not unsupervised is very important. And the second one I want to talk about is vascular dementia, and either the second or third most common cause of dementia, depending on how you define these diseases and which study you're looking at. So it's the result of reduced blood supply to the brain. So blood supply, there are different vessels in the brain, and oxygen is carried by the blood to the brain. So when there's reduced blood supply, there's reduced oxygen going to the brain. And when there's reduced oxygen to the brain cells can start getting affected and they might start to die. So that's what happens when someone's having a stroke, in which that there's a major blood vessel that is blocked. And then now no blood is getting into certain areas of the brain, and those brain cells will start to die. And then that's why they would have these acute symptoms when they experience a stroke, such as having numbness and weakness on one side of their body or having difficulties with speech. And with a stroke, usually people recover in the first 6 months to a year. Sometimes with a really major stroke, and for someone who's a lot older, they might not fully recover. And then for people with a history of multiple strokes, they could be at risk for vascular dementia, in which that they never fully recover from the strokes, and now they have chronic cognitive problems that are not going to recover back to baseline. And it doesn't have to be a full-on stroke for vascular dementia to happen. So as we grow older, and especially for people with some chronic health conditions such as high blood pressure, high cholesterol, you might start to have a buildup of cholesterol plaque within the walls of the blood vessels. And that can also reduce the blood supply going to the brain. So even though it doesn't fully block the vessels, there's still not enough oxygen and blood going to the brain. And over time, if that's significant enough, it can also cause vascular dementia. In terms of symptoms, it really depends on which blood vessels are affected and which areas of the brain those blood vessels are supplying blood to. So symptoms might vary. But in general, people with vascular dementia may be slow in processing information and having difficulties with complex tasks. And they might also have memory difficulties as well, but it's very different from the kind of memory difficulties that we see with Alzheimer's disease. Because in Alzheimer's, they're really unable to form new memories. So the information is really gone. Whereas in vascular dementia, the information usually is still in there, but they might have difficulty getting it out. So sometimes giving them a hint or a cue might help them retrieve the information. The next I want to talk about is Lewy body disease, which is also the second or third most common cause for dementia. And it's the result of buildup of abnormal proteins in the brain. These are different proteins from the ones that are seen in Alzheimer's. So these are called alpha-synuclein inclusions, or Lewy bodies, as they're also called. That's why it's called Lewy body disease. And the symptoms, there are very specific symptoms that are associated with Lewy body disease. So the first is fluctuating attention and alertness. So that's when someone might not be able to sustain attention very well. They might be easily distracted. They can have long periods of staring into space, having episodes of drowsiness and taking long naps during the day. They might have good days and bad days, so really have seeing those fluctuations. They might have visual hallucinations as well, which is when you see things that are not there. And it's the hallucinations that are seen in Lewy body disease is very different from the ones that we see with psychotic disorders, such as schizophrenia. Because first of all, schizophrenia usually onset much earlier in life, usually in late teens and early adulthood. So if it's an older adult without a history of any psychotic disorders and symptoms, suddenly having hallucinations is more likely to be something going on neurologically rather than having a primary psychotic disorder. And also with schizophrenia, you're actually more likely to have auditory hallucinations, which is hearing voices that are not there, and usually pretty scary voices. Whereas in Lewy body disease, it's visual hallucinations, and it's usually of people or animals, and they're not usually scary to the individual. So it's not like in schizophrenia where you're hearing voices that are telling you to do something bad. REM sleep behavior disorder is also another common symptom of Lewy body disease, which is when you act out your dreams. So REM stands for rapid eye movement. It's one of the sleep stages in which that usually our body is almost completely paralyzed. Whereas for people with REM sleep behavior disorder, their body isn't paralyzed on what they're supposed to. They're actually moving, acting out their dreams. And sometimes people might hurt their bed partners as a result. Motor problems are also common in Lewy body disease, and these motor problems are usually similar to what we see with Parkinson's disease. For example, having slow movements, hand tremors, problems in walking, and stiffness. And then in terms of cognition, besides the fluctuating attention that we talked about earlier, people with Lewy body disease have difficulties with processing visual information and difficulties with complex tasks. And these are usually worse than what we would see with Alzheimer's disease in the same areas. So Lewy body disease actually is commonly misdiagnosed because, as you can see, there are a lot of different psychiatric and motor symptoms that can also look like other disorders as well. So for example, the late actor Robin Williams, he actually was misdiagnosed with Parkinson's disease when he was alive. And then it was only during autopsy after his death, it was revealed that he actually had Lewy body dementia. And then the last disease, and really this is a syndrome that I want to talk about, is frontal temporal dementia. So the frontal temporal dementia is a little bit different from some of the ones that we've been talking about, in which the onset is usually a little bit earlier, so before the age of 65. And it's caused by a variety of different pathologies, depending on which variant of the syndrome it is. So people can have Alzheimer's disease pathology, meaning that their brain has the Alzheimer's disease proteins that we see, or they can have other abnormal proteins such as tau and TDP43. So that's why it's called a syndrome. Frontal temporal dementia is really called a syndrome because it's specific symptoms rather than a specific disease that we're talking about. And there are 3 different variants for frontal temporal dementia. The most common variant is the behavioral variant of frontal temporal dementia, and it's characterized by personality changes. So people might become more inappropriate. They might have inappropriate comments and behavior. They might be more impulsive. They might have poor judgment, not having insight into what they're doing, and also losing their empathy as well. Whereas the language variant, which is also called primary progressive aphasia, is characterized by language problems. So people might have difficulties producing speech, getting the words out, or they might have difficulty understanding language. And then the motor variants, these are some different disorders that are associated with the motor variants. So we have ALS, or amyotrophic lateral sclerosis. So that's also known as Lou Gehrig's disease. So that's characterized by muscle weakness, and people eventually become fully paralyzed. Cortical basal syndrome is when you have abnormal movement in one side of the limb. So your arm and leg on one side, at least at first, and then it spreads to the other side. And then progressive supranuclear palsy is characterized by abnormal eye movement and difficulties with balance and walking, and they oftentimes have frequent falls because of the balance issue. So if someone doesn't really have physical problems that might interfere with walking, but they're falling all the time without really knowing why, then PSP is something that should also be considered as a differential diagnosis. So even though usually you fall into one prominent type based on your symptoms, people actually can have mixed symptoms as well. So if you have the language subtype, you can also have some personality changes that are maybe a little bit less prominent. Or if you have the behavioral or motor variants, you can also have some subtle language problems as well. In terms of how we assess dementia, so the first thing any doctor would do is really try to get a good history of the symptoms. So getting a sense of, what came first? How progressive is the disease? How is it progressing slowly, or is it very sudden? What was the first symptom that people see? So getting family members' opinions about, especially people who live with the patient, is really important on, what was the first thing you saw and how is it affecting your daily activities? Because as I said before, that's a very important part of the diagnosis. And then they might also refer for a neuropsychological assessment, and also a neurologist might also do a neurological assessment. So neuropsychological assessment is a comprehensive examination of cognition. So usually they test different areas of cognition, such as memory, attention, processing speed, and so forth. And that usually takes a while, at least an hour or two, sometimes even longer. A neurological exam is something that a neurologist would do during their visit, where it usually takes about 10-15 minutes, and they go over different senses and movement and balance. They might also do a brief cognitive screener. A lumbar puncture is something that they can also use to assess dementia as well. It's also called a spinal tap. That's when you take the fluid surrounding the spinal cord, which is also the same fluid that's surrounding the brain as well, and see if we see any protein markers for different diseases that we're considering. So there are a number of Alzheimer's disease biomarkers that have been established that you can get through lumbar puncture. That's mostly used in research, but sometimes also used in clinical settings as well. So that can give you a sense of, whether they might have Alzheimer's disease. But it's important to note that it's really looking at these proteins and whether there might be evidence of a disease process, but not actually looking at the symptoms. So there are people in research studies where they don't have any symptoms, but when you do a lumbar puncture, they might have Alzheimer's disease biomarkers in their cerebrospinal fluid, but they might never actually develop dementia in their lives. And then it's unclear why that is. There's different theories and research about, why someone might have this pathology, Alzheimer's disease pathology in their spinal fluid, but then maybe they have something that's protecting them from developing the symptoms. So it's not always a one-to-one correspondence. And then neuroimaging can also be used to help the diagnosis with dementia, although it's a little bit less definitive than a lumbar puncture would. So you can use a CT or MRI scan, which looks like the structure of the brain. So we can see whether there's shrinkage in the brain, whether there's shrinkage of specific parts of the brain that's associated with certain diseases. We can also use those scans to look at strokes, bleeding, tumor, excess fluids. And then the PET or SPECT imaging is a functional scan in which we try to see how the brain functions. So we can see whether there's any abnormal blood flow in specific parts of the brain, or we can look at metabolism that's associated with specific neurotransmitters or chemical messengers that are in the brain. And there's certain diseases that have certain abnormal functioning in the neurotransmitters that we can take a look at as well. So currently there is no cure for dementia, and there really isn't any treatment that can actually improve symptoms of dementia. So there are some medications that have been developed for Alzheimer's disease, and most of them are trying to regulate activities of certain neurotransmitters, which are the chemical messengers I just talked about, that are affected in the brain due to Alzheimer's disease. Recently, there has been a new drug that was approved by the FDA that aims to get rid of beta beta amyloid plaques, which is one of the pathologies that we see with Alzheimer's disease. And it's the first that has been approved by the FDA that targets the underlying pathology of Alzheimer's disease. But there are some controversy with the new drug because it did receive an accelerated approval. So some people are concerned about how fast it was approved. And also in clinical trials, even though it's shown effective in getting rid of the plaques, it didn't really improve any of the symptoms of Alzheimer's disease, which is kind of important. So that's why there's some controversy with this new drug. So people should talk to their physicians, about what works best for them, whether that's something that they want to use. And the medications for Alzheimer's disease are a little bit more developed than other dementia because Alzheimer's is also just the most studied dementia. So sometimes for other dementias, they might also use some of these drugs for Alzheimer's because there just aren't other drugs that are available. And then there are different rehabilitation and therapy approaches that people might have to improve their quality of life, to live better, to have a better quality of life living with dementia. So for example, in cognitive rehabilitation, the therapist can teach patients how to compensate for their difficulties. So maybe teaching them different memory strategies and remembering their appointments and remembering their medications so they can function better, or teaching them different language strategies that they can communicate with their loved ones better. Occupational therapy are people who work with caregivers to try to help the patients perform their everyday activities to the best they can. So maybe making sure that they have a pill box if they're having difficulties with managing their medications, or making sure that there is a security system at home so patients don't wander off and get lost. The physical therapists can also help patients increase their physical activities in a safe way. And that's especially important for people who are prone to losing their balance and falling. And as I'll talk about later, exercise is very important in maintaining brain functions. So even for those with motor problems, it's very important to exercise. So physical therapists can really help with that, especially for patients who have difficulty doing exercise the traditional way. And the speech and language therapists can help family and caregivers communicate better. For patients with difficulties with language, they can also help them develop maybe nonverbal strategies and try to communicate. So these are just some of the approaches that that patients might be able to do usually in a big multidisciplinary dementia clinic. So there are hereditary forms of dementia, and these are deterministic genetic mutations, meaning that if you have 1 or 2 copies of a specific genetic mutation, you will develop the disease later. These are a very small percentage of cases. In Alzheimer's, less than 1% of the cases are actually these hereditary forms of dementia. It's a little bit higher than in frontal temporal dementia, in which 20 to 30% are hereditary in this way. But in general, people with a family history of dementia, it does put you at increased risk of developing dementia. So this might be because they have other genes that we haven't identified in research that is associated with dementia, or maybe they have a risk gene. So not a deterministic gene, a risk gene, meaning that if you have this genetic mutation, then you're more likely to have dementia, but it doesn't mean that you definitely will. So one of the most widely studied, one of these risk genes is the ApoE gene. And if you have the allele 4, depending on whether you have 1 copy or 2 copies, making you more at risk for Alzheimer's disease. So it does put you at increased risk, but just having this doesn't mean that you definitely will. There are people with the ApoE allele 4 variant who never actually develop Alzheimer's disease while they're alive. And the good thing about this is that even though there is the genetic component, we know that 35% of dementia cases are attributable to lifestyle factors that can be changed. So there are things that we can do right now to try to maintain our brain health and delaying the onset of dementia, preferably to after death, right? If you can delay it long enough that you'll never actually experience it while you're alive, even though you might have the genetic predisposition for. So these are some strategies for maintaining brain health. So even though there isn't one definitive way that we can do to say prevent dementia, if you do this, then there won't be dementia. That doesn't exist. But there is this combination of different lifestyle risk factors that we can try to improve in order to maintain our brain health. And you can do everything on this list, then you are very far along in trying to maintain brain health and delaying the onset of dementia. So the first is to maintain your physical health. So there are chronic conditions that are listed here: high blood pressure, diabetes, obesity, and smoking. These are all conditions that are really bad for the blood vessels. So there's a vascular risk. So remember earlier I talked about how if you have reduced blood supply to the brain, that's bad for cognition. So trying to prevent these conditions or making sure these conditions are treated is very important. And they're also the same thing that affect heart disease as well. Again, these are all things that are related to the blood vessel. So anything that you can do that's good for your heart is actually good for your brain. Exercise is very good at reducing vascular risk factors that we just talked about. It's also good for reducing inflammation, increasing blood flow, and creation of new brain cells in the brain. So exercise generally is very good. Maintaining mental health is very important. Depression specifically has been associated with a higher risk of dementia. So making sure if someone is depressed, they're getting treatment for is very important for maintaining brain health. Making sure someone is socially engaged is very important as well. And this is true. This is definitely very important for individuals as they get older. They might be retired, so they might not be as socially engaging. And then they might also have other colleagues and friends who have passed away, or maybe their kids don't live close to them, and they might become socially isolated. And we know that being socially isolated is very bad for health in a number of domains. So your physical, mental health, they can all be affected by social isolation, and that does include brain health as well. So making sure people are getting socially engaged. If they don't have the family members close by, maybe they can go to local senior centers or go to local events for seniors, to making sure that they have those connections. Engaging in cognitively stimulating activities are very important. So think of the brain as like any muscles in your body, right? So if you want to build up your muscles and maintain them, you need to go to the gym and work out, right? So it's the same thing with the brain. You want to maintain brain health, you need to work out the brain. So making sure that you are doing things that are challenging mentally is very important. And that becomes more challenging when someone retires. Again, during their job, they might have done a lot of cognitive activities, but maybe after they're retired, they don't do much. And then it's important to find things that you can do that are challenging to the brain. So maybe doing crossword puzzles or board games. I think learning a new hobby and language is very good, because learning new things is really stretching your brain. And then diet. Really just eating a healthy diet, first of all, is good for your vascular health, right? Preventing all the health conditions that we just talked about. And then that in turn will affect will make your brain health better. And there is a diet called Mediterranean diet, which has been associated with lower risk of dementia. So Mediterranean diet basically just consists of low meat and dairy intake and high fruit, vegetable, and fish intake. So it's found to reduce vascular risk and inflammation. So that's why it's good for the brain. But you don't necessarily have to go by the Mediterranean diet. I think just eating healthy, not eating so much meat and eating a lot of fruit and vegetables is definitely something that you can do right now. And then finally, sleep. Having good sleep is also very important for brain health. So it's really a myth that older adults don't need to sleep for as much as younger people. They might have difficulties with sleeping more, and their schedule might be more shifted, but older adults should still be getting 7 hours of sleep for most people. Some people might be different, because some people might be able to go by with less sleep, but in general, they should be sleeping more, and that's good for the brain. And if they have any sleep disorders that are untreated, it's important to treat them because that can also improve cognitive functioning as well. So one of the most common sleep disorders is called sleep apnea, and it's more common as you get older, and especially if you have the vascular conditions like high blood pressure, diabetes, where sleep apnea is just means that there's not you stop breathing momentarily multiple times during the night as you're sleeping. So then that can be easily treated with a CPAP machine. And then people usually, if they're having cognitive issues because of sleep apnea, usually after they get treatment, their cognition is noticeably better. So that's another modifiable risk factors that we can do right now. So in summary, we talked about signs of cognitive decline that's beyond normal aging. So I think it's really when everyday activities start to require more effort, or if you require assistance, that's when there might be concerns of this might not be just normal aging, it might be something else. They might want to see a neurologist for another workup, and they might refer you to a neuropsychologist and other practitioners to do a full assessment. We talked about different diseases that cause dementia, Alzheimer's disease being the most common. Currently, there's no cures or treatments to really improve the symptoms of dementia, but we're all working on this. So hopefully there will be. But we do know that 35% of dementia cases are attributable to modifiable risk factors. So being physically, socially, and cognitively active and maintaining physical and mental health are all things that you can do right now. So again, I want to thank you so much for letting me present to you about this information, and I will take any questions.
Thank you so much, Dr. Chen. So I have a couple of questions. What are some ways for folks who are not the primary caretakers? What are some ways that they can help their aging loved ones maintain brain health?
So if they're not primary caretakers, I think try to increase the frequency of check-ins are important. So if you notice any changes from your loved one's previous levels of functioning, and also just helping these older individuals have this social connection. As I said, the social engagement part is very important, and work with the primary caregivers in trying to help their loved ones increase more activities and finding things that are in their neighborhood that they can do, an activity that they can do, and providing the primary caregivers with the social support will also be good. It's not just good for the caregivers, but also good for the patient, right? When the caregivers when their stress is reduced, I think it's better for the care of the patient too.
Thank you. That kind of leads me to my next question. So living with an aging loved one can be stressful. Do you have any suggestions on what specific strategies families can try to ensure brain wellness for all in the home?
So I think it's very important for caregivers to really be mindful of their own self-care. So really making sure that you're still carving out time for doing things that relaxes you and help you de-stress. If they feel like they need help beyond what they can do for themselves, there are also support groups in which that they might be able to join, right? They can talk to other caregivers who are in the same situations, and sometimes just having other people validate your experience can be very helpful, and you can share different strategies on how you can de-stress and take better care of yourself. And also I think to just improve brain health for everyone in the family, I think try to do a lot of things together. Try to do things that are physically, mentally active, trying to attend social events together. I think that's really good for everyone's brain health.
Thank you so much. One last one. As an older adult, what are some questions I should ask? Excuse me. What are some questions an older adult should discuss or ask their doctors during regular checkups? We'll all be older adults one day, so I'm sure this will be important for me to know too.
So I think if they're experiencing things in which they feel like, oh, that's different from my friend who is the same age, and I feel like these are the things I did before and I did very easily, and now it's very difficult to do. I think that's something that it's important to bring up to your physicians in your regular checkup. just so to get their opinion and see maybe they need to refer you to a specialist for a further a fuller assessment of maybe, you know, it's dementia, or if it's something else, it could be other modifiable conditions as well. I mean, I don't know if there are other specific questions that you would ask. I think it's really important to speak up if you have these symptoms. And if there are things that you feel like you're having these symptoms and it doesn't seem to be explained by your current conditions, I think it's important to ask your physicians about what they think about maybe there's something else that's going on. Maybe it's the brain, because there's a lot of symptoms like psychiatric or motor, these things that we think that it might be related to a specific organ, but then it might not be. It could be the brain, because the brain really controls all organ systems. So so it could be the brain, and it never hurts to see a neurologist. If it's not dementia, great, right? But it's good to rule that out, right? If you're concerned about. And because I'm a neuropsychologist, I might be a little biased in thinking that everyone should get a neuropsychological assessment. I think it's important sometimes even to just get a baseline, because sometimes what we see is that we have patients and they come in, they do this assessment, but sometimes it's unclear whether there's a decline or whether this is how they've always been. So if you had a baseline, and we can compare you to that baseline, that's actually very helpful clinically in seeing, oh wait, there actually is a decline, and I have this objective score so that I can say that statistically this is a decline from your previous levels of functioning.
That's great. Thank you so much for this informative presentation and for answering these questions. And to everyone who's watching, thank you for joining us. If you aren't already following us, you can check us out for more informational content on here, Instagram, Twitter, YouTube, by searching and finding our tag Rutgers IFH. We'll be back here on Thursday to bring this information in Spanish. Thank you again for joining IFH's Community Classroom. Have a great day.